Hey everybody, welcome to Ask Dr. Testosterone, starring Dr. George Touliatos, all the way from Athens, Greece. He is the author of Bodybuilding, the Good, the Bad, and the Ugly, available on his website, gtool.com, gtoul.com, as well as amazon.com. He's also a monthly contributor to Muscular Development Magazine, and in this, what month is this? The August issue with
August, yes.
Great cover, Steve Laureus. Is that a cool cover or what?
Taper, yes, excellent.
There is an interview with Dr. In addition to his regular column, there's an interview by Tim Zakorski conducted with him called "The Testosterone Doctor is In." It's a great feature.
This is cool, huh?
Yeah.
Nice.
And you know, the doctor talks about his own experiences as a bodybuilder, using anabolics and other drugs himself, which is why he's able to help you guys the way he is, because he's walked the walk. He's used these compounds. He knows what effects they have on the body, both in terms of how you look and feel and the actual blood and labs and all that stuff. So welcome, Doctor. How are you today, sir?
Excellent, Ron. Thank you. Have a nice it's 8 weeks until the Olympia now.
Yeah. It's coming up. How's
I think it was in pretty good shape in London. Friel was.
Yeah.
I believe 8 weeks of hard dieting, he can be on stage.
He could do it. Will he though? I'm going to find out soon. I'm going to find out very soon. I'm tracking.
Does he have to give an official statement about this, to sign a contract or something?
Well, I think they can do whatever they want. Like, I remember, was it 4 years ago, Kai Green? It was like the Thursday before the Olympia when it finally came out that he wasn't going to do it. But
can he make it as Arnold in Sydney, where he appeared in the press conference and nobody knew?
Wouldn't that be awesome? Yeah.
Yes.
Well,
super surprise.
He wouldn't really, because a lot of people are wondering if he's going to do it. With Arnold, I think it was a complete surprise that year. Like, nobody knew. Nobody. Except Franco. But, yeah, I'd love to see Phil do it. I'd love to see Kai do it. You know, I want the best guys in there.
But so far, as it is now, my money bet on Winkler in case he comes shredded to the rear, and of course Brandon Curry. He can make it. He can double his trophies, Arnold Classic and Olympia, like Ronnie, also like Cutler. No, Cutler didn't do it. Dr. Jackson also did it.
Yeah.
08.
Ronnie did it one year. He won the Arnold and the Olympia also.
He could hardly, 2002, yes.
But, yeah, we'll see. We'll find out soon. He's got to give us an answer soon. Like I said, I'm tracking him down. Okay. Well, guys, you have sent in your questions for the doctor, and the doctor is ready. Your first question.
Yeah, the forum was full of questions. The forum was full of, we dig up questions from the forum.
Yeah, yes. we only used about, I'd say about a third of all the questions this time. Yeah, because we're getting a lot of questions. We're not telling you guys to stop sending questions, not at all, but thanks for the questions. Okay, so this is a very, very common concern, especially in these warm months. Question number 1, what could be the most effective but relatively safe fat loss protocol for a contest diet, Doc? I assume he's talking about the drug aspect.
Yes.
Okay.
So the major drugs that we use in order to enhance fat loss and beta oxidation of adipose tissue, in other words, to catabolize fat, is the ECA stack, which is ephedrine, caffeine, and aspirin, and mainly it's ephedrine, which is anorectic and also thermogenic. And ephedrine, it has a shorter half-life than clenbuterol, so it's used pre-workout in order to have intensity, but also anorexia during dieting. And we use it, we combine it with aspirin, with caffeine that have synergistic effect. Also caffeine is thermogenic and anorectic. Yeah. And aspirin acts as a blood thinner, and also in cyclic AMP is a catalyst. And also all this stack favors fat loss. Now, one is this. The other combo, which is actually more potent, is triiodothyronine or T3 along with clenbuterol. Now, the point is with thyroid hormones, if they can, in the long term, and while abusing them, they can lead to muscle catabolism. But on the other hand, we have the anabolic stack that prevents this. Actually, getting ripped is anti-catabolic effect. We do not gain muscle during getting shredded, but we preserve muscle and we kill the fat. So clenbuterol, yes, technically it's an anti-asthmatic drug that opens the bronchi and the trachea, okay, and you respirate more, you increase your VO2, and in this way you utilize more oxygen, and you have heart rate increased, respiration also, and through this the whole metabolism is elevated. Okay. Also we have sweating, okay, restlessness. So yes, all these agents, T3, T4, clenbuterol, ephedrine, and caffeine, even amphetamines that also are anorectic, they induce catecholamine release, adrenaline and noradrenaline. And everything that elevates heart rate is boosted by epinephrine and norepinephrine. These are the two major hormones. Okay. And now, conservative doses, okay, there was a typical protocol that I read it in the late 90s on Bill Phillips' book that was supposed to be 25 ephedrine, 250 caffeine, and 500 aspirin. Actually, the ephedrine tablets came in 50 milligrams in Spain and in Turkey, and using 50 milligram was a really large dose, okay? It's kind of risky if you use also high caffeine doses. And aspirin, as a matter of fact, it's also risky for those that have GIT bleeding and ulcer. Wow. Now, clenbuterol, I suggest to start low and go slow and elevate it gradually. However, because we get accustomed and very used the saturation of the receptors, the beta-2 agonist receptors, we use two days on and 2 days off the clenbuterol. So the first week we use 20 micrograms, which is one pill, Monday, Tuesday, and then we take off Wednesday and Thursday. Now the second week we elevate this to 40, then to 60, to 80, to 100, which is 5 pills because they come in 20. Yeah. A regular safe dose would be 120 micrograms, that means 6 pills, okay. 2 a.m. or 3 a.m., 3 p.m. Now, the clenbuterol has a half-life of 48 hours, therefore it has to get rid of the system 2 days. That's why we follow the 2 on, 2 off. Okay. Then we discuss also that Zadifen, ketotifen, is introduced into the game because of the saturation of the receptors, that this drug is also able to unblock them. If you go higher than 100 micrograms, 120, then you start having headaches and heart rates and palpitations in the thorax, yeah. Heart, yes, and this nasty headache is back in your cervix. Jeez. And this is elevated blood pressure. Okay. Sometimes we have nose bleeding from the high blood pressure and from the high hematocrit. I have also visualized videos of powerlifters that squat 1,000 pounds, yeah. And they start bleeding. This is horrible. Mm. This is explained by 2 factors: high blood pressure and high viscosity. Mm. And this bleeding does not, the thrombosis lacks, the thrombotic effect is lacking because INR is prolonged due to the steroid abuse. Therefore, a cut does not stop in 3 minutes, but in 5 minutes. Mm. So in a stroke and internal bleeding, it's poor, the prognosis. Yeah. Hmm. Yes. So this is my Ecastac and Clen T3 and also amphetamines. Now T3, I suggest to start low from 25 micrograms. T3 has a shorter half-life than T4, therefore has to be administered once a day. However, it's more potent than T4 in the myocardium, and also more potent, more effective for fat loss. However, what I want to mention is that T3 monotherapy leads to decrease in T3 and T4 because T4 is the basic thyroid hormone that manufactures T3. It converts to T3. That's why all the hypothyroidic patients receive in first place the T4 that also forms T3. Therefore, I suggest if you want to use T3, do not do it for a prolonged time. Also, always do pyramid, 25, 50, 25. Yeah. Otherwise, combine T3 with T4. T4 needs once a day because it has a prolonged half-life, unlike the T3 that needs AM, PM. Okay. And there comes a point that after prolonged abuse of thyroid hormones, your TSH goes sky high, and there your gland is not effective, and this is where it comes like a replacement therapy for life.
Damn.
Yes.
That's permanent damage?
I think so, yeah. It's very sensitive, the thyroid gland, and there is no turning back. So this axis is sensitive. What I want to say is that all the CNS stimulants, they provide 20% of fat burning. The real deal is there are no shortcuts. The train hard and diet hard. Empty stomach cardio, okay, whatsoever, we know the drill. And also we have the growth hormone that also burns fat, and stay away from DNP. Dinitrophenol is a poison, and it's for desperate people who are lazy, they want shortcuts, and they are not afraid. I mean, they're daredevils.
Yeah.
It interferes with mitochondrial activity and metabolism, and you can have fever actually, even during winter time. It's horrible. Some people claim it's safer because it does not interfere with heart rate and myocardium, but people have died of DNP, and it was a drug for plant-based material. Yes.
Yeah, they were killing. What do you call it? Like like a weed killer, something like that, for your garden. Anyway. Okay, that was a very nice overview of fat loss drugs, Doctor. Okay, here's one some guys have a lot of concern with. It would be nice to cover the topic of gyno development after a cycle, in my case 3 months after, and how to manage it in case of steroid use. For sure, I'd say not aromatizing products, or if aromatizing products are used with it, anti-aromatase or anti-estrogens. Any suggestion on the best approach would be appreciated. So I'm not sure if he's asking, does he already have gyno and he's trying to figure out if there's drugs to take to get rid of it, or if he wants to prevent getting gyno after a cycle. I'm not really sure what he was asking. Are you?
No, but I want to say in first place that gynecomastia is something that does not happen to all people, to all men. Right. Some are prone to this, like myself. I'm sensitive. When my estradiol goes over 50, my nipples are pumping out and I'm more itchy. Of course, gyno is more nasty, okay? Yeah. And some people also are, they do not have any kind of symptom, even though their estradiol is approaching to 3-digit numbers. Yeah. So another thing is that people have also removed their glands, therefore we forget about this.
Well, they don't have to worry ever again.
Yes. Yeah. Also, another thing is that there are two different kinds of drugs. The SERMs, okay, the selective estrogen receptor modulators, that are clomiphene citrate and tamoxifen citrate. They're used in breast cancer, but what they do is occupy the steroid receptors. It's like sitting on a chair, and the other estrogens are not able to sit on the receptors. But the floating estrogen, they still circulate. Therefore, you occupy the receptor of the estrogen receptor, but the floating estrogen still exists. On the contrary, the potent aromatase inhibitors, they cut off the enzyme aromatase that converts testosterone and androgen to estrogens. Yeah. And therefore, you cut off all the production of estrogens in first place. Now we have 3 basic drugs: anastrozole, letrozole, and exemestane. Now, exemestane is a suicidal aromatase inhibitor that is supposed to keep low the estradiol and all the estrogens even after you stop the use of it. So it's considered to be the more potent. And some links and some sites point out that it's more friendly to the lipids and basically on HDL crash. The dose of anastrozole is 1 milligram, of letrozole is 2.5 milligrams, and of exemestane is 25 milligrams. So our people are cutting into 2 or into 4. Now, it depends how high is your estradiol. When somebody asks me about gynecomastia and tenderness, I told to undergo a blood work. The best blood work is E1, E2, E3, and prolactin. So estrone, estriol, and estradiol, and then also prolactin, because there are some drugs and some cases that prolactinemia also pumps out the nipples, okay?
Yep.
Especially also when estradiol is high, which is the main representative of the estrogens. And yes, high estrogens, on the one hand, high estrogens may favor thrombosis, also foggy mind, bad mood, bloating, edema, but also too low estrogens may have dry joints, aching joints, okay? Poor erection also, bad mood, lack of pumping. So it has to be in a sweet spot, as Dr. John Crislow used to say, 25 to 50. Of course, 3-digital estradiol is super high,
Yeah.
but some people feel good even at 70 or 80. Yes, it's strictly personalized, and estrogens have two sides. They're necessary for a man's libido, but also they can lead to side effects, also crashing on them. So you have to do balance. Balance is the key.
Gotcha. Okay. All right. Next one is, hello, doc. This is my question I've been thinking about for a while. If Andriol, the oral drug which is testosterone undecanoate, which is oral and the same as Nibio injection, testosterone undecanoate, can all injectable testosterone be taken orally?
So this question basically compares the two testosterone undecanoates in injectable form and in oral form, Peros.
Yeah.
Because actually, Andriol or Restandol in Greece, it's the oral form of Nebido or Avid.
Yeah.
So this is an oily capsule, Andriol, orange color,
Yeah.
which means it has to be absorbed with a fatty meal, not with water. And if you don't want to have a fatty meal, you can just you're going to have just a small amount of peanut butter, for instance. Now, it is not liver toxic because it bypasses the portal circulation, but it is utilized and it enters the lymphatic circulation because lymph leads with fat absorption.
Yeah.
Now, unlike the testosterone undecanoate that has to be injected once every 60 or 90 days, the Andriol has a very short half-life and has to be administered with meals. For instance, 5 times a day.
Wow.
Okay, it's not like we take one once for all, like the Nebido, but we have to take it under constant use because of the shorter half-life. But it's also the cost effect is higher with Andriol. The 30 caps cost about $10.
Oh.
And if you need 5 caps a day, then every week you're gonna need the $10. Okay. But it's more convenient for guys who don't want to undergo injections. Of course, there are also the transdermal application with gels.
Yeah.
And yes, on the other hand, Nebido is so prolonged that after the first injection, you're gonna understand an effect in libido and in mood after the first 4 weeks. So it was very slow up.
Wow.
However, when it start working, you're super high because of the 1,000 milligrams of testosterone you have introduced. So therefore it spikes in estradiol, also it spikes on DHT, you're super high, and you're excellent in mood, but you may be more edgy and irritated. The second month, from week number 5 to 8, it stabilized, it hits a plateau, and then it starts declines. Therefore, week from 9 to 12, you're gonna feel drained, low, because it's the lowest levels. This is the bad side, that it has no steady levels, unlike the daily application, either in injection or in gels or in capsules. It's more convenient for guys who travel and for those who are not used to injections.
Sounds terrible. Nebido sounds like you have all these fluctuations with the levels, though, over the months.
Yes, 4 injections in one and very slow release. And if you want to get rid from the Nebido protocol, you have to wait for at least 1 month to 6 weeks in order to start using another ester, because ester is like a vehicle, slow, faster. So get out of your system and start using another vehicle.
Yeah. So I guess his question was, because it's the same drug and it comes in an oral form and injectable form, he's asking, could he take the injectable form, just squirt the Nebido oil into his mouth, just like he does the pill?
No way, no way. No, the pharmacokinetics are more different. No,
Yeah.
no, no.
And I mean, he's asking, can you do that with any test like Testosterone or an anti?
No,
I think he wants to drink all his test or put it
no.
under his tongue. No, not going to work.
Oh, the ester separates from the drug as soon as it gets into the bloodstream. Okay.
Yeah. Okay. So this can.
These solutions are made for intramuscular use, even subcutaneous in some cases, if you apply very small doses. But no, this is supposed to be into the muscle.
So don't go drinking your Testosterone, guys. It's not going to work.
Dan Duchaine used to say this with Winstrol. You can drink the Winstrol in case you have abscesses in your glutes or in your delts from injectable Winstrol. It's the same way as taking pills of Winstrol if you drink it.
So Winstrol is the only injectable that you could actually drink.
I mean, Dan Duchaine said that, and I verified this with Patrick Arnold 3 years ago, and he agreed that it was mentioned by his mentor, Dan Duchaine. I don't think suspension testosterone can be drank, but Winstrol was the exemption, yes.
Okay. Well, this is kind of a tricky question here. My question is, what is the maximum dose of AAS, anabolic androgenic steroids? I mean, does he mean the maximum safe dose? This is a tricky.
Okay.
How do you tackle this one, Doc?
Okay, I can speak for my experience, what was my maximum doses that they also explained in the interview in the magazine.
Right.
But I'm going to tell you the other way. What are the minimal doses that can work? Okay, because I'm not allowed to speak maximum doses, and this is not for medical supply, not for medical use, it's unethical. Okay, because decadrobulin is supposed to work medically in 50 milligrams per week, and bodybuilders use 10 times this dose.
Yeah.
Same with testosterone, we use even less than 200 milligrams a week, and bodybuilders go up to 2 grams.
Easily, yeah.
The same for Anavar. Anavar is used 5 or 10 milligrams for burns or cahexa or whatever, and bodybuilders go to 50 or 100 milligrams. Okay, but what I know from my circles that Deca works from 400 milligrams and more. Equipos, roughly the same, but these are enhancing effects. Okay, and sometimes people say more is better. More is not better because we have the saturation theory of the receptors, and then you have the bloating effect of aromatization that does not lead to muscle growth, but just to water gain. Also matters about nutrition, diet, and of course how you exercise. So it's not just one parameter of drug use, it's also 2 other parameters as well, and also genetics and rest.
Right.
So safe dose, what I call safe dose for myself is to use 200 milligrams of Primo per week, 100 milligrams twice, or 30 milligrams of Anavar or Winstrol orally because it has a half-life of 8 hours, so to be steady within your blood. But you're going to tell me that these doses do not work. Obviously they do not work because they are not, for instance, they may work for some guy who's a beginner or a starter, but will do nothing for an advanced bodybuilder.
Yeah. Well, people can see it in the interview, but you actually listed your stack for the last contest
yes, in the book was a hardcore cycle.
Yeah, I mean, I'm just.
For instance, Testosterone has to be applied 4 times a week, every other day. So we get to 400 milligrams.
Yeah.
Okay. The same with Trenbolone acetate, for instance.
Yeah.
Every other day goes to 400 milligrams as well.
Wow.
Testosterone propionate, you can use 400 milligrams if you use 100 milligrams every other day, or 800 milligrams if you use 2 mLs.
Yeah. Because this is what you said. You did last 2 weeks before your final show. Okay, so this was the last 2 weeks was the heaviest part of the cycle.
Yes, it was not prolonged. It was just a peaking.
So it was 50 milligrams of fluoxymesterone. What's it? Halotestin? Yeah.
Yes.
50 milligrams oxandrolone, Anavar. This is every day. 50 milligrams stanozolol, Winstrol. 50 milligrams exemestan, AM, PM. What is that? I'm not even sure.
I was using 2, the aromatase inhibitor.
Oh, okay. Okay. 50
Aromacin a day, AM and PM.
Oh, that's aromacin. Okay. 100 milligrams mesterolone. Which is
for proviron a day.
It's proviron. Okay. 100 milligrams test suspension. 100
Yes.
100 milligrams trenbolone base, along with
Yes.
albuterol L,
Yes,
T3,
this was
T4.
pre-workout. So pre-workout, I was using the injectable form of Winstrol, testosterone suspension, and trenbolone suspension, the base. Yes, because it's very utilized very fast.
I mean, looking back, would you have used those same amounts, or would you use less? Even though it was only 2 weeks, do you think you could have gotten
No,
same
they was
results?
just taking for my before the show, just before my depletion and during my depletion,
Yeah.
and of course the week of the depletion, which is the week before, you cut off the injectables.
Okay, that's true.
Yeah.
Next question. Does HCG work if you have primary hypogonadism? In regards to being low T and young, would HCG still work if it's a testicular problem? Or should I freeze my sperm before I start TRT? I'm 28.
Now, before using TRT, you should do a seminal diagram, because exogenous testosterone will shut off HPTA and, of course, spermatogenesis, FSH, and Sertoli cells production. Now, you can along use HCG with TRT, it's called HRT, and providone also, that helps restore fertility and keep fertility to a fair level. I did myself. For 3 years, I was using every day 100 IUs of HCG, and I managed to triple my sperm and froze it. Why? Because I had to. There was no more manufactured the Pregnil. Now we have another version of Ovitrel, but Pregnil was the best to using very small doses every day. Now, what about the question in first place? Primary hypogonadism in medicine, we have, for instance, in Klinefelter syndrome, which is the 47XXY. That these men they have a female appearance with gynecomastia, with no pubic hair. Okay, they do not shave also. These guys, these men from puberty, they use for life testosterone. And they have testicular failure, yes, and very high LH-FSH, because as a compensatory mechanism, the brain works very hard to wake up the testicles, but they do not respond. However, under anabolic steroid-induced hypogonadism, as it happens with Thomas O'Connor and steroid users, there is the late onset, which is primary, which is in first place primary hypogonadism, that turns to secondary. So a steroid user progressively will lead to testicular failure and low testosterone, low testicles, but still the brain will work. This is hopeful, and this gives some hope, because the brain is the key, hypothalamus and pituitary, in order to wake up the testicles. In this case, we may use the PCT protocol with HCG and SERMs, and I have seen some cases that total and free testosterone elevate along with this protocol. However, the secondary hypogonadism is non-reversible. There's no hope to be recovered, and then you use the TRT and HRT. So yes, it's more promising, the primary hypogonadism. You can restore it with HCG along with SERMs, along with clomiphene and tamoxifen. These two agents work for the same reason, but through different pathways. So HCG in first place, and then SERMs in second place, and then you have the final result. Yes, I believe within 4 or 6 weeks you can restore, you can become from hypogonadic to eugonadic, but also, of course, needs time. Time is a healer, and stay away from steroids.
Okay. Our final question this time. Hematocrit has been a topic that the doctor has informatively visited on many occasions. It also has been a rather controversial subject in the world of TRT and anabolic use. My question is, are there any precautionary steps or supplements one can take to control hematocrit levels while on cycle and or TRT? I've read that yerba mate, good hydration, and cardio are all effective regulators of hematocrit, but is there any data?
Yes, of course. We can use grapefruit, which has an arginine, which is a compound that it seems promising in avoiding erythrocytosis. Also, as prevention causes, we can cut off red meat and iron. We can use more white meat, because for the formation of hemoglobin, the substrates are iron, folate, and B12. Therefore, we can avoid red meat, and we can use more fish and white meat. And of course, as precautionary methods, we can use salicylic acid or aspirin. And for those that have enzymatic deficiency of G6PD, they can use fish oil, DHA, and EPA. They act as against platelet aggregation as blood thinners. All right. Also, avoid smoking, because smoking introduces carbon monoxide that gives a signal to kidneys for hypoxia. Kidneys release EPO, and EPO goes to bone marrow and produce red blood cells. Also, avoid staying super high, above 2,000 meters or 5,000 feet. So people in Mexico have higher hematocrit because they live in 7,000 feet.
Oh, geez.
Indians, they were red. They call them red skin.
Yes.
Because they were living up in Colorado, in the mountains of Colorado.
Oh.
The American ancestors. Yes. When I went to Denver, there were pictures of Indians in the walls of the airport.
Yeah.
That's
where Phil Heath lives. That's where Phil Heath lives.
Yes, and also Big Billy. And also, you have to hydrate, because what happens with hydration is you kind of dilute your plasma. So if you are dehydrated, you have the pseudo elevation, the false elevation of hematocrit, but not hemoglobin. Therefore, hemoglobin is more accurate because it's a protein and it's steady. However, hematocrit is affected by hydration. Therefore, if you are dehydrated, your hemoglobin stays the same, but your hematocrit elevates. Now, if you drink a gallon of water before your blood suction, you're going to have a pseudo dilution and a lower falsely hematocrit. It's a trick because you dilute.
Right.
And there you have the water intoxication that bodybuilders go to the day before the show, because they drink tons of water and then they cut it abruptly in order to get eliminated of water.
Yeah.
Yes, these are the basic. And then, of course, yes, blood donation, phlebotomies, and lower, of course, your steroid use or your replacement therapy protocol. Some people are prone, as I said in my last episode of this IPB Pro. Some other guys are within cycle and they have just 50%. And some people they have this kind of miserable thing. They will never become anemic, but they have to get rid of the blood. Sometimes life is weird. Some people die from anemia and some people die from too much blood.
Yeah. It's crazy. Okay. Well, Doctor, that is all the questions for this week. Everybody keep the questions coming. We don't get to all of them, but we do try our best. The doctor chooses the ones he feels are going to do the most good for the most people out there. And again, pick up your copy of his book, Bodybuilding, the Good, the Bad, and the Ugly, on his website, gtoul.com, gtool.com, or amazon.com. And a very, very honest and upfront interview with the doctor where he talks about his own steroid use and competitions and all that, plus many other topics in the August issue. What a great cover, Steve Laureus. Go pick that up. August issue of Muscular Development. Dr. Touliatos, thank you again so much.
Welcome. Thank you to Steve Blackman, editor, and also Alan Golnick, and you also for making this interview, publishing this interview.
Cool. Well, everybody, thank you all for watching Ask Dr. Testosterone. Keep the questions coming. He's here to help, and we appreciate it very much. Thanks for watching. Bye-bye.